Okay, good morning, everybody. I'm Shikha. I'm one of the sleep fellows. Today I'm going to be talking about Parkinson's and sleep. All right, so our learning objectives today, we will be reviewing Parkinson's disease and its pathophysiology. We will classify some common sleep disorders in patients with Parkinson's disease in relation to various brain structures, and then explore some management options of sleep disorders in patients with Parkinson's. So the reason I'm doing this talk was because of a case I had with Dr. Patil a couple months ago. So we had a 56-year-old female, history of Parkinson's. She had a lot of sleep-related challenges, was having trouble falling asleep, staying asleep. She had a lot of excessive daytime sleepiness and these sudden sleep attacks. She did have restless legs, but she said they were pretty much controlled, but occasionally it would pop up again, and she was noticing it was occurring earlier in the evenings, sometimes going into her arms as well. She reported issues with some compulsive shopping. She was getting like Amazon packages every day, sleepwalking and eating behaviors at night. And then she had tried many different medications such as trazodone, mirtazapine, nortriptyline, Benadryl, and melatonin for her insomnia, but none were working. And she was currently managing her Parkinson's with rotigotine patches for her tremors. I guess she had tried carbidopa, levodopa, but it didn't really work. And surprised, they were helping her restless legs.
Who was she referred from?
Her
CWRU or neurology?
neurology. So we will start by just doing an overview of Parkinson's disease. So first, it was described as the shaking palsy by James Parkinson in 1917. Jean-Martin Charcot proposed its current name honoring him. Other names that they had called it was Parkinson disease, idiopathic of primary Parkinsonism, hypokinetic rigid syndrome, and paralysis agitans. So who gets Parkinson's? So prevalence is about 94 cases per 100,000 people, so about 0.3% in the general population. Year incidence of new cases is 8 to 18.6 per 100,000 person per year. Risk factors, age is a big one. Incidence and prevalence rise pretty steadily in adults beginning in the 5th decade. Males tend to get it more than females. Some genetics, family history of Parkinson's in a first-degree relative is associated with a 2 to 3-fold increase in the risk of Parkinson's. They have the monogenic forms, which are less than 10% of Parkinson's patients. These include those that are autosomal dominant, autosomal recessive, and X-linked. And these patients tend to have a younger onset compared to the sporadic cases. Some genes that I found, these PARK7 was a big one, GBA, and then the LARC2, which had more of a later onset. Environmental exposures are there as well. So things like pesticides, air pollution, well water use, high iron intake seems to be a risk factor for Parkinson's. And then comorbidities, so high BMI, history of TBI, diabetes, melanoma, prostate cancer. So just some neuropathology to kind of remember Parkinson's disease. These are kind of the 5 hallmarks of getting Parkinson's disease. So the big one that we know, progressive degeneration of dopamine here in the substantia nigra pars compacta. This is where these neurons are what make dopamine, which is needed for coordinating movement. And as these neurons degenerate, dopamine levels decrease, which leads to the motor symptoms in Parkinson's. And then our Lewy bodies down here. This is another significant feature. The presence of these abnormal protein aggregates are called Lewy bodies. These protein clumps primarily consist of alpha-synuclein, and they are normally found in the presynaptic terminals of the neurons. So in Parkinson's disease, alpha-synuclein aggregates form these Lewy bodies, which can disrupt cellular function and contribute to neuronal death. And then we have inflammation in the brain, which is mediated by activated microglia and other immune cells. This is increasingly recognized as the contributor to Parkinson's pathology. The chronic neural inflammation can exacerbate neuronal damage and contribute to disease progression. And then the dopaminergic neurons in the substantia nigra called neuromelanin over here. This is a dark pigment. It plays a role in protecting and in detoxification. And in Parkinson's, it's that characteristic pallor that we see on the autopsies. And then we have the locus ceruleus, which makes norepinephrine, the dorsal motor nucleus of the vagus nerve, and various cortical areas that also lead to the neuropathology. That's a mouthful, I'm sorry. So symptoms of Parkinson's disease, we all know the motor symptoms and the triad of movement disorder. So bradykinesia, worsening resting tremors and rigidity, also the masked facies, slow gait, frequent falls, slow reaction time. There are also the non-motor symptoms, so things like difficulty swallowing, cognitive impairment, GI issues, and then anxiety, depression, and sleep issues, which are less talked about here. So now we can go into Parkinson's and sleep. So why is sleep important in Parkinson's? So like I just mentioned, the non-motor symptoms, this is what leads to the cognitive decline, progressing onto dementia. 80% of patients with Parkinson's experience sleep disorders, but as many as 30% won't discuss it with their physicians. This leads to a lot of increased risk of falls and injuries in these patients and exacerbation of their Parkinson's symptoms.
Any reasons for why they won't discuss?
I don't know, I
They
think,
suggested.
I think just they have so much other stuff going on that it's like the last thing. Yeah. So common sleep disorders in Parkinson's, we have circadian rhythm disorders, insomnia, restless legs, sleep disordered breathing, excessive daytime sleepiness, and then REM behavior disorder. So all of them. So what causes sleep disturbance in Parkinson's? So what we know about Parkinson's, the degeneration of dopaminergic neurons in the substantia nigra and depletion of dopamine in those pathways are the hallmark of Parkinson's, and they're responsible for the motor symptoms. But what I found was this thing called the Brock hypothesis, which basically is saying that the neurodegeneration of Parkinson's starts lower in the brainstem. And it progresses following like an ascending pathway upwards, which is what is causing some of these non-motor symptoms that's happening in Parkinson's disease. So the microbial products, they come into contact with the olfactory and the enteric neurons. They trigger the aggregation of alpha-synuclein over here. And then this spreads towards the central nervous system via the olfactory bulb and the vagus nerve here. And then eventually the aggregated alpha-synuclein arrives at the substantia nigra. So the involvement of these extranigral structures, so the hypothalamus and the brainstem, leads to the non-motor manifestations, and this is what kind of contributes to disrupted sleep.
How many people have heard of Brock? You guys heard about it? It's relatively new, but it's really kind of like really important because they say you see the two ways you can get into it. One is through the gut, when it goes up through the vagus, and then the vagus comes in there. So that's maybe why the brainstem and dysarthria and speech and all that sort of stuff that they talk about. And the other one is the olfactory nerve. That means you get. Is this sort of like a prion disease sort of thing? Is it a virus sort of thing? Because you get into that's why the smelling stuff is so, you've seen that stuff. And so I don't know who here focuses on Parkinson's. They seem to be dementia more than anything else here. But when you sit there and you realize that how does it get from your gut all the way up into your brain? How does it get from your olfactory to your brain? That's a really different mechanism of diseases you can think of. Right, so I've really been intrigued by this. I don't know how you intervene. I don't know if you biopsy a gut, do you find whatever it is that's in there? is the GI upset? They talk about constipation as being one of the major symptoms of Parkinson's. But is that the first symptom that you should sit there and worry about? If that is, everybody is all they need to see probably. And whether you can do it by through your nose or through your gut, or is it just eating something and going up through your olfactory? Because your olfactory are your oldest nerve in the body and it goes everywhere. So I just wanted to point out that it's a mechanism of disease thing, and that's why it affects everything in sleep. I mean, everything in the brain. It's medicine, sleep. Parkinson's is sleep.
Yeah.
Okay, sorry.
No, thank you. So some other things that contribute to sleep disturbance in Parkinson's, so degeneration of the noradrenergic and orexin producing neurons. So this contributes to things like excessive daytime sleepiness, sleep attacks, and those narcolepsy-like features that these patients will have. There's this thought of the degeneration of the SCN and the clock gene suppression, so leading to circadian rhythm disorders. There's a lot of alterations in circadian rhythm that's been seen in Parkinson's. They seem to have this blunted circadian rhythm, which is shown by a reduced amplitude of the melatonin rhythm and overall lower circulating melatonin. So possibly a degeneration of the SCN, which is leading to that in Parkinson's. And then degeneration of the ceruleus and subceruleus complex leading to REM behavior disorder, which I'll get into here. So I just thought this was a nice picture, kind of putting it all together of all the different things that go into sleep disruption in Parkinson's. The etiology is clearly very multifactorial because of all the degenerative processes underlying the disease and their interactions with various drugs and the clinical features. I did see sleep architecture alterations in Parkinson's. PSG showed reduction in total sleep time and sleep efficiency, increased wake after sleep onset and arousals, and overall sleep fragmentation. Not regarding changes in sleep stages, it was reported less frequently. It does differ among stages of Parkinson's, so those who are advanced have maybe less slow wave sleep compared to early stage. Common syndromes that can affect sleep in Parkinson's, so of course, REM sleep behavior disorder, RLS, sleep disordered breathing, and then medications play a really big role, which I'll talk about a lot. Dopaminergic medications have been linked with daytime sleepiness and sleep attacks, and they do correlate with total daily dose. So that is pretty important. So we can start now with insomnia. So insomnia, sleep fragmentation occurs in about 81% of patients. It appears that sleep onset is less common than sleep maintenance, although the patient we saw did have sleep onset insomnia as well. Insomnia appears to be the most common complaint among Parkinson's patients and their sleep, and they may predate onset of motor symptoms in Parkinson's disease. So that neurodegeneration of locus coeruleus, raphe nucleus, pedunculopontine nucleus as well. More common causes of Parkinson's would be a combination of motor and non-motor symptoms in Parkinson's from other sleep disorders. So things like RLS or OSA, and then these questionnaires are pretty helpful in these patients looking at their nocturnal symptoms. So the PDSS is the Parkinson's disease sleep scale. They use questions asking about tremors and mobility, dystonia, hallucinations, nocturia. They now have a PDSS-2, which is more revised. It includes things like restlessness and cramping on there as well. And then the NMS is a 30-question questionnaire and assesses multiple motor and non-motor domains, including sleep dysfunction.
What do you think of
They-
PDSS? I've never seen it.
Yeah, I should have put a picture of it out here.
No, I mean, is it? I mean, it's sort of like our, pretest probability or probability tools for things, and whether or not it's any based on these guys, that's all. Yeah, we should know that. That's why that's how you hit the department chair. Yeah.
So insomnia and motor symptoms. So motor symptoms can affect insomnia in Parkinson's patients. It's 60% of the patients. They'll have nocturnal tremors, dystonia, akinesia, restlessness. There was a cohort of 412 patients with Parkinson's, 51% had trouble with initiation of sleep or fragmentation. A lot of them will have different fluctuations of tremor and rigidity. A lot of their medications will wear off in the evenings as well. So that could be contributing to that. So treatment of the nocturnal symptoms, it's similar to daytime motor symptom treatment. You can use controlled release carbidopa, levodopa at bedtime to improve nocturnal akinesia. No significant change in objective sleep measures is what I found. Extended release forms of dopamine agonists. So rotigotine effects on nocturnal and early morning motor fluctuations were evaluated via PDSS-2, showed significant improvement of overnight tremor and dystonia and the ability of them to fall asleep. Long-acting ropinirole and immediate release pramipexole. Sustained release pramipexole, it has demonstrated benefit on sleep compared to the immediate release form. In a trial I saw, there was a 6.8 point difference in the mean PDSS score at 18 weeks, and that trended towards being significant. The MAO-B inhibitor, so rasagiline, was also evaluated by the PDSS. It was shown to improve nocturnal tremor and restlessness, and patients reported improved ability to fall asleep and reduction of nocturnal awakenings when they use this as adjunctive therapy, not by itself. And then deep brain stimulation. Yeah.
I guess because it's an hour.
Yeah. Deep brain stimulation, that's when they put the surgery, they implant to help with tremors, but can also be used for motor fluctuations. Total sleep time increased by 1 hour in each trial in earlier studies. In later studies showed improvement in tremor, akinesia, and dystonia up to 3 years post-implantation, but it's not to be used specifically to treat sleep issues in Parkinson's. And then looking at insomnia and non-motor symptoms of Parkinson's, the big one is nocturia. So detrusor muscle overactivity from autonomic dysfunction. Roughly 35% of patients have nocturia and subsequent frequent nighttime awakenings. Treatment focused on behavioral interventions is something you can start with, but it doesn't always help. So reducing fluid intake. The medications I saw, solifenacin, it's a muscarinic inhibitor with minimal CNS penetration. There was a prospective study for urinary dysfunction in Parkinson's that showed improvement. Trospium and mirabegron are not really studied as much in this patient population, but can be options as well. And then other non-motor symptoms in insomnia for Parkinson's, mood disturbances, it plays a really big role due to neurotransmitter changes as the disease progresses. Serotonin may also play a role. And there seems to be a reciprocal relationship between poor sleep and mood disturbance. Presence of one will worsen the other. And then this was just one of the many studies I saw looking at sleep disturbances and depression severity. This one, they evaluated patients with and without Parkinson's using ISI and the Beck's Depression Index to measure the impact of insomnia and depression. Total sleep time in patients with Parkinson's had a greater correlation with depression severity than that in the controls, just showing that there is that synergistic effect of depression and Parkinson's on sleep duration. So how do we manage insomnia and Parkinson's? It's very tricky. CBTI can be something that can be used. Exercise. Most antidepressants can exacerbate RBD and RLS. You guys know which one doesn't? Bupropion. Medications are not really studied in patients with Parkinson's. Chronic benzodiazepines and BZRAs can lead to chronic cognitive decline and dementia. So would recommend a very limited course of them or melatonin receptor agonists over other hypnotics. Doxepin less than 10 milligrams appears to be relatively favorable. And then suvorexant is pretty safe in the elderly, which we're trying to get for our patient from our case earlier.
So, Shikha, were there specific studies of these hypnotics in Parkinson's that you were looking at?
Not specifically in the Parkinson's population. It was very,
So we're extrapolating data from the Parkinson's populations
yeah.
primarily.
Mhm. So I just thought this was an interesting study, because I mentioned that exercise can be helpful in insomnia. This was the RCT of exercise in objective and subjective sleep in Parkinson's disease. We found that exercise improves motor symptoms and subjective sleep quality in Parkinson's. They looked at if high intensity exercise rehab with resistance training and compared with sleep hygiene controls. So they looked at people with Parkinson's. They were randomized to exercise that was supervised 3 times a week for 16 weeks. They had 27 people in that group versus a sleep hygiene alone group, which had 28 people. They had a PSG at baseline and then at post-intervention, and the primary outcome was change in sleep efficiency. But they also looked at these other things as secondary outcomes. So wake after sleep onset, total sleep, sleep latency, slow wave sleep. Results showed that the exercise group had significant improvement in sleep efficiency compared to with those who only had sleep hygiene alone.
Interpret that again. So on the vertical axis is change from baseline to post-intervention, and there are positive numbers for wake after sleep onset.
Yeah,
So improve sleep efficiency.
yes.
So 38% versus. I just don't understand the metric. I mean, I know what they've interpreted in the paper about,
But
it's a strange.
But
Wouldn't it have been negative?
compared to no
Yeah, don't you want,
exercise?
don't you want to have wake after sleep patterns that decrease?
Yeah, that's right. Yeah, that's true. So I don't know about that one.
Yeah.
Yeah, that one goes up.
Yeah,
That
the other ones make sense.
total sleep time goes up. Right? It's weird.
Yeah.
See, there you
I
go.
guess that was the question. This
Yeah.
also actually got worse.
Yeah. And then they also looked at them and they had them do, let me see here. So they looked at acute and chronic. So the AEX is acute exercise versus chronic exercise here. They did 3 PSGs at baseline, post-intervention on an exercise night, and then post-intervention on a non-exercise night here. Actually showed that chronic exercise improves sleep efficiency more than acute, total sleep time as well, slow wave sleep, and then wake after sleep onset went down with chronic.
So that's the same study. Maybe-
Yeah.
So maybe just misrepresentation.
The editor. Now, the Clinton Clinic was the first people,
Yes.
and there's that lady over there who's on the news that does ultra marathons with Parkinson's, says it's erased her tremor.
Oh.
Ultra marathon, yes, yes.
So this just kind of summarizes everything I just said. So insomnia and Parkinson's due to motor symptoms, nocturia, anxiety, depression, and the treatments I discussed. So nextly, we'll talk about REM behavior disorder. Okay, so prevalence in the general population is 0.5 to 1%. The prevalence in Parkinson's is up to 60%. So you have that lack of normal skeletal muscle atonia during REM sleep, leading to the dream enactment behaviors or bed partners talking about kicking, punching in their sleep and injuring themselves. The thought is that accumulation of alpha-synuclein in the pontine nucleus, as well as a sublateral dorsal nucleus, ventral medium medulla, send these inhibitory projections to the spinal motor neurons during REM sleep. And for many patients with Parkinson's, these symptoms will precede motor manifestations and them even having a formal diagnosis of Parkinson's. So it is an opportunity for possible early diagnosis. So management, so number one is always to evaluate safety. Look at their, make sure they have bed rails on their beds, no weapons near them, cover any sharp corners. Sorry. And then taking a look at their medications that could be worsening RBD. So all these medications can make RBD worse. So SSRIs, SNRIs, TCAs, alcohol, caffeine, various antipsychotics as well. And then looking for pseudo RBD. So that could be due to untreated OSA. So making sure if they do have OSA that is treated. And then as far as medications, clonazepam and melatonin are the two big ones. Clonazepam at doses of 0.25 to 1 to even up to 2 have been studied. Melatonin at high doses, 10 to 15 milligrams. And then these acetylcholinesterase inhibitors, so rivastigmine and donepezil, have limited evidence. Clonazepam is the most studied treatment for RBD, and it works, but should be used cautiously in these patients. These few studies I saw were kind of conflicting. The first one was prospectively studied recently. They had 15 patients with RBD studied on clonazepam compared with PSG and RBD severity scales to 42 untreated patients. Clonazepam increased total sleep time and decreased wake after sleep onset compared to controls. And the percent of rematonia was not significantly different. The RBD severity scores on clonazepam didn't change much in follow-up in 2.6 years. The second one was an open label study. They followed them for the 2.6 years. 67% had complete elimination of sleep-related injuries. And then we had the only RCT using clonazepam in patients with RBD and Parkinson's didn't show any superiority over placebo in a 4-week trial. But they were only treated with 0.5 milligrams, so maybe doses greater than 0.5 will be more effective. And then melatonin for RBD, this is also commonly seen. Doses from 3 to 12 milligrams have been seen to be effective as monotherapy or adjunctive with clonazepam. Double crossover placebo-controlled trial was done, showed 8 patients with RBD over 4 weeks, and they had significant improvement on rematonia on PSG and the melatonin group. 2 subsequent RCTs used 2 to 4 milligrams of extended release melatonin, did not show superiority over placebo. So that greater dose seems to be what works best. And then there seem to be mixed results with the use of Ramelteon. And then other treatments for RBD and Parkinson's, limited success or applicability. So acetylcholinesterase, this rivastigmine. In this study, they used it as an alternative treatment for those who had failed clonazepam or melatonin. They used 4.6 milligram patch for 3 weeks, and it did reduce frequency of RBD episodes from 4 to 2 a month. And there was no change in the placebo group. And then looking at restless legs.
Is that available? Is that man available?
Rivastigmine, I'm not sure.
Yeah.
May have to work with a neurologist.
Italian names are.
Restless legs, so prevalence in those with Parkinson's 8 to 40%. The mechanisms appear to be poorly understood. There's a thought that the CNS iron levels are reduced. Treatment is pretty, it can be challenging in these patients, making sure to review their medications. So a lot of them are on a lot of those dopamine agonists already. So it's interesting to think that maybe some of it is a little bit masked because they're already on these dopamine agonists. Their restless legs may be underestimated, or when they do come to you, they may be coming to you in a state of augmentation, which I'll get into here. So behavioral pharmacological approaches, avoidance of alcohol, caffeine, medications. It's not really studied in the Parkinson's population, but iron can be used just like we use in our regular restless legs patients. Clinical response, 50 to 60% of patients experience improvement, but it is typically delayed by 3 to 5 weeks. And yeah, it's not extensively studied in Parkinson's population. So treating them in Parkinson's, so the dopamine agonists, they are effective, but may lead to augmentation, as we know. I just find it very interesting. So RLS can be underestimated in Parkinson's because they're already on these agonists or levodopa. But because these medications they're on, they may already be experiencing augmentation. So when they come to you with these issues, it's a lot of them will say they used to have restless legs, it got better, and now it's worse, and they've been on these medications for so long. We've noted that these agonists are linked to impulse control disorder. So 10 to 15% of Parkinson's patients will have this impulse control disorder. And augmentation is associated with a 6-time higher risk of developing impulse control disorders.
Right, the patient we saw together.
Yeah.
They had a lot of impulse issues.
Yeah, she was doing a lot of shopping
Yeah,
and
online shopping.
yeah. So it's interesting and it's very challenging because getting them off of these medications that they're on by their neurologist for their Parkinson's, and our patient specifically was helping her tremors, whereas nothing else was helping. So it just poses a really big challenge. Other medications to help treat them, the gabapentin, pregabalin seems to be the best option for these patients. There is this deep brain stimulation I keep seeing everywhere. So there was a study with 31 patients. 6 of them developed RLS 6 months after having the deep brain stimulation implanted. But those patients were on high doses of dopaminergic medication. So possibly could have been from augmentation. There was another study with 22 patients undergoing deep brain stimulation. They showed improvement in RLS scores 2 years post-surgery despite reduced dopaminergic medication. So it could be an option. Next, sleep disorder, excessive daytime sleepiness. So initially in Parkinson's, they'll have about 15 to 21% of patients will have this, but as the disease progresses, you'll see up to 46% of patients will have this complaint. Does seem to fluctuate over time. It's not persistent, seems to be linked with the male gender, cognitive decline, autonomic dysfunction, hallucination, and advanced disease. Etiology, so loss of the hypothalamic neurons that secrete hypocretin, and lower levels of hypocretin in the CSF have been noted in Parkinson's patients. Autopsy studies showed that loss of hypocretin secreting neurons seems to parallel Parkinson's disease progression. And then a lot of studies showed that the dopaminergic medications, specifically levodopa and agonists like pramipexole, ropinirole, rotigotine, cause somnolence, like in our patient as well. So patients taking these medications were sleepier than those treated with levodopa alone. Combination therapy with levodopa and a dopamine agonist was associated with the highest risk of excessive daytime sleepiness. So it does appear to be dose dependent, and higher doses are found to be associated with those irresistible sleep attacks. So how do we approach these patients? So we need to differentiate between sleepiness and fatigue. Using things like the Epworth Sleepiness Scale may be helpful, and then getting some objective data from a PSG or MSLT. Management, we really need to tailor individually to each patient, making sure they're not driving while sleepy, trying your best to get rid of those medications that can cause hypersomnolence, although it can be very tricky if they've been on these things for a long time that are helping their other symptoms, addressing their nocturnal symptoms, so like kinesia, tremor, urinary frequency, causing them to not sleep well at night or making them sleepy during the day. Watching out for sleep attacks can be caused by dopamine agonists, and then trying to consider dosage reduction, maybe working with the neurologist to see what you can do. Some trials on medications, modafinil has been studied a few times. They had multiple RCTs that evaluated the use of modafinil. They had a crossover study, showed significant reduction in Epworth Sleepiness Scale with modafinil up to 200 milligrams daily compared to placebo. The second one showed that modafinil 200 improved ESS compared to placebo as well. And then a larger study was a follow-up study with 40 patients, didn't find that modafinil up to 400 milligrams reduced Epworth Sleepiness Scale significantly, but they had a mean reduction of only 2.7 after 4 weeks of treatment. And then sodium oxybate, I found this RCT with only 12 patients over at University Hospital in Zurich. They titrated the patients from 3 milligrams to 9 milligrams. They were taken at bedtime and then 2.5 to 4 hours later. Primary outcome measure was a change of objective excessive daytime sleepiness by MSL and MSLT. Secondary outcome was the Epworth Sleepiness Scale and sleep quality. Baseline measures, the MSL at baseline was 3 minutes, and then 14.3 points on the Epworth Sleepiness Scale. Final doses of the study of the medication were 4.8 milligrams, or 4.8 grams, of sodium oxybate and 8.7 grams of placebo. Sodium oxybate improved excessive daytime sleepiness both objectively and subjectively. In the 12 patients, the MSL improved by 2.9 minutes and Epworth Sleepiness Scale by 4.2 points. You can see that here.
Shikha, I know those studies were focused on the sleepiness problem, but did they happen to just look at the Parkinson function? Like, just did that change or worsen or improve?
So from not specifically this, but all the treatment studies in Parkinson's for daytime sleepiness did show that cognitive function improved. That was the big one, but a lot of the other stuff, not so much.
So, yeah, so motor symptoms didn't necessarily change.
No.
Zurich University Hospital is a big neurology area. Who is
Richard,
the guy?
Richard Logan, or I don't know the guy, Conrad, no, he's pulmonary.
He,
You mean now?
it'll fly by in a second. But I don't know if he's still there because we went to another, he changed hospitals because of some fluff. Well. Ooh, almost.
It'll come. And then now we have obstructive sleep apnea and Parkinson's. So found in up to 50% of Parkinson's patients. OSA in Parkinson's is not greatly evaluated. Most of the literature has either a lot of limitations with small sample sizes or inadequate control groups, a lot of confounding data. But it did show, most of the stuff shows that either the rate of OSA in Parkinson's at least matches in those without, or there's a higher rate. Snoring and apneic episodes may be up to 3 times more common in Parkinson's. The upper airway muscle dysfunction due to akinesia or dyskinesia can lead to OSA. A lot of oral breathing associated with open mouth from advanced stage Parkinson's seems to play a role as well. And then dopaminergic medication excess and withdrawal can lead to a lot of respiratory muscle dyskinesia, leading in dyspnea, tachypnea, irregular breathing patterns. And then levodopa, which a lot of these patients are on, induces a lot of oromandibular or laryngeal dystonia as well. The pathophysiology of levodopa related respiratory issues, not super well understood, but it's probably associated with the denervation of hypersensitivity of dopamine receptors or in the peripheral chemoreceptors. So there's some kind of role there. So sleep apnea and the risk of Parkinson's disease. This was a longitudinal population study, showed that patients with sleep apnea were at higher longitudinal risk of Parkinson's. Age and male sex are independently associated with the risk as well. So increased risk of developing Parkinson's in those with OSA relationship is driven by men in age of more than 60. This kind of just showed at the end of the study that chronic intermittent hypoxia increased oxidative stress and inflammation, contributing to the pathophysiology of Parkinson's. So it's kind of interesting. So disease-free survival rates over here in time, and these dotted lines here are the people with sleep apnea. This year looked at the bidirectional association between Parkinson's and OSA, was a cohort. They compared the OSA group and non-OSA control group. They compared the incidence of Parkinson's in individuals with OSA to those without. They used hazard ratios. Let's see, the adjusted hazard ratio for Parkinson's patients with OSA was 1.54, so 54% higher likelihood of developing Parkinson's in individuals with OSA compared to those without. They also looked at the effect of OSA surgery on the incidence of Parkinson's disease. The hazard ratio of 0.47 suggested a significant reduction in the incidence of Parkinson's among those who had surgery for OSA compared to those who didn't.
That's wild.
Yeah.
That's wild.
And
I mean,
they,
that's the Kaiser code down there. in LA. That's wild stuff.
I think it's a Korean thing.
It's Korean,
I think this is
yeah, it was South Korea.
South Korea.
Yeah.
Because they have big data sets, so that's what they did.
Yeah.
That's how they would do that.
Yeah.
That's wild. Look at that.
I
10
have
years out.
over 6,000 patients in the OSA group.
Well, I see it's like 0.5% to 1.5%. So it's significant. Vertical axis is really. That's impressive. That's a surgery fact.
Yeah, so OSA might be associated with increased risk of Parkinson's, but surgery for OSA could potentially lower this risk. Pretty interesting. They didn't specifically say which surgery they did.
Probably some stuff.
Yeah. So does treatment of OSA reduce Parkinson's incidence? There's a lot of literature that supports this. Although CPAP has not been extensively studied in the context of Parkinson's due to some challenges with adherence and tolerance and compliance. There was this prospective observational study, 67 patients with Parkinson's had a PSG. Those who had moderate to severe OSA were offered CPAP. They followed them from 6 to 12 months. At 6 months, those with CPAP for 1 month were considered CPAP users. At 12 months, only those using CPAP were included in the group. The results showed that CPAP treatment of OSA and Parkinson's associated with improved overall non-motor symptoms, sleep quality, anxiety, and cognitive function at 12 months, but nothing with motor function. But I would say yes, CPAP is shown to improve excessive daytime sleepiness, overall improve their non-motor symptoms and cognitive function. Next, we have circadian rhythm disorders, our last one. So circadian rhythm dysfunction in Parkinson's disease. So the hypothalamus is affected in Parkinson's disease, can lead to decline in SCN activity responsible for reduced melatonin output and sleep-wake disruption. Defective pathways here leading to malfunctioning effects and alterations in their circadian rhythmicity. This all leads to reducing sleep quality, daytime alertness, and cognitive performance. The BMAL1 expression clock gene, dopamine. So we know that dopamine regulates BMAL1 and clock gene activity. So dopamine deficiency can directly affect the central component of the molecular clock. And then considering that dopamine plays a crucial role in the circadian process of sleep, it should be plausible that interconnecting relationship of different brain structures associated with sleep can lead to different sleep disorders. Also, those with Parkinson's have reduced mobility, leading to less exposure to outdoor light. So how do we treat these patients? So kind of similar to how we treat those who don't have Parkinson's, melatonin at bedtime shows improved sleep quality, no improvement in motor symptoms at night. Bright light therapy, morning or evening, improve motor symptoms and mood symptoms. So the bright light seems to help a lot. Evening light has been shown to have more of a significant improvement in motor symptoms, and studies showed that some of them even needed less doses of levodopa. So,
You didn't keep the dog away?
Maybe,
oh,
pause the sharing, and you can see the Hollywood squares.
okay.